Today, we're diving into a spinal condition that's incredibly rare, notoriously tough to diagnose, and just exceptionally challenging to treat. We're going to go deep inside the thoracic spine to really understand this high-stakes medical problem, and it all starts with just how rare this thing really is.
Take a look at this number, 1 in a million. Yeah, according to the research, that's the odds of having a thoracic disc herniation that actually causes symptoms. It's so uncommon that a lot of doctors might go their entire career without ever seeing a single case. And that, of course, makes it so much harder to diagnose. For the person who has it, it's a huge challenge for them and their surgeon.
So, what are we actually talking about here? Well, put simply, a thoracic disc herniation, or a TDH, is when one of those cushiony discs in the middle of your back, that's the thoracic region, bulges or just ruptures. And that bulge can press directly on one of the most critical things in your entire body, your spinal cord. To really get why this is such a huge deal, we have to look at the anatomy of the thoracic spine itself. See, it's not like your neck or your lower back. The differences are exactly what makes this whole condition so incredibly risky.
It really all comes down to space. The spinal canal in your mid-back is just incredibly narrow compared to the spinal cord that's running through it. Unlike other parts of the spine, there's basically zero wiggle room. And that means any little bit of pressure, like from a herniated disc, is felt immediately and, well, intensely.
So there are a few things that really stack the deck against this area. You've got the natural forward curve of the thoracic spine, which is already kind of pushing the cord toward the discs. You combine that with that super narrow canal and these things called watershed zones, which are just areas with a really fragile and limited blood supply. And, well, you've got a recipe for danger. Any compression here, especially around that common T11, T12 spot, can damage the cord very, very easily.
Okay, so if you're the patient, how in the world would you even know you have this super rare condition? The journey to getting a diagnosis, it turns out, often starts with a bunch of confusing and really varied symptoms. Now get this. Our source material shows that a staggering 92% of patients get thoracic back pain. But the other symptoms, they can be all over the map. You could have weakness or coordination loss in your legs, bladder issues, even weird abdominal pain. And it can all be coming from that one tiny compressed spot in your mid-back. This makes getting an accurate diagnosis and getting it quickly a real challenge.
And that is the critical question, isn't it? With symptoms that are so all over the place, doctors can't just take a guess. They have to see exactly what's going on inside the spine.
And this is how they do it. This right here is an MRI from the case of a 51-year-old patient. And you can see it, clear as day. Those red arrows, they're pointing to the piece of the disc that has herniated out and is pushing right into the spinal cord. There's no guesswork here. The imaging gives you the proof.
And this is absolutely crucial, that imaging does way more than just confirm there's a problem. For a surgeon, an MRI or a CT scan is basically the blueprint for the entire operation. It tells them not just where the hernia is, but how big it is, and, this is critical, whether it's soft or if it's hardened and calcified. That one detail completely changes the entire surgical strategy. And that brings us right to the surgical crossroads. Once a TDH is confirmed and the more conservative treatments haven't worked, or maybe there's been a really bad trauma, the patient and the surgical team, they're facing a massive decision.
You know, surgery isn't the first option they jump to. The criteria are really specific. It's for patients whose symptoms are getting worse and worse despite trying other things, or it's for those emergency situations where some kind of trauma has caused a really severe and dangerous compression on the spinal cord. Okay. Now this slide is so important. There is no single best way to do this surgery. It is a really complex trade-off. You've got the anterior approach going in through the chest that gives the best view of those central calcified discs, but it carries risks for the lungs. Then there's the posterolateral approach from the back. It's safer for the lungs, but you can't see those tricky central hernias very well. It's a real balancing act, and the surgeon's choice completely depends on the specifics of each patient's herniation.
And this is the question that every single patient and every doctor has to face. Even with the best possible plan and the most skilled surgeon in the world, operating this close to the spinal cord comes with some pretty significant risks.
So let's just be direct and look at those risks. Understanding what can go wrong isn't about scaring people. It's a critical part of the surgical reality and making sure patients get the best care.
So a meta-analysis cited in our source, that's a big review of a bunch of studies, found that the morbidity rate, which is just the medical term for the rate of complications, for this surgery can range anywhere from 12% all the way up to a really sobering 48%. That huge range really just highlights how unpredictable and complex these procedures can be.
So, when things do go wrong, the problems usually fall into three big buckets. You've got issues with the lungs, the potential for neurological function to actually get worse, and then breaches of the dura, that's the protective sleeve around the spinal cord.
Lung problems are pretty much a direct consequence of that anterior approach we just talked about. I mean, when surgeons have to go through the chest cavity to get to the spine, it can lead to things like a collapsed lung or fluid buildup, and that can really prolong how long a patient has to stay in the hospital.
This is probably the most feared complication. Remember those watershed zones with the very fragile blood supply? Well, even the tiniest disruption during surgery can cause what's called an ischemic injury, basically a loss of blood flow. And that could potentially lead to symptoms getting worse, or in some really rare, terrible cases, even paralysis.
And finally, dural breaches. Imagine the spinal cord has this thin, protective sleeve around it. When a disc hernia is calcified and hard, it can get stuck to that sleeve. So when a surgeon tries to remove it, it can tear, causing a leak of cerebrospinal fluid. This can lead to horrible headaches and other neurological problems, and sometimes it even requires another surgery to fix the leak.
So, after going through the anatomy, the diagnosis, the tough surgical choices, and all the risks, let's kind of pull it all together and see what the big picture really looks like.
Here are the crucial takeaways. First, thoracic disc herniations are so serious precisely because of the unforgiving anatomy of that part of the spine. Second, precise imaging isn't just for the diagnosis, it is the roadmap for the surgery. And finally, that surgery is always a calculated balance of risk versus reward, where preparing for complications is just as important as the operation itself.
And all of that leaves us with one last thought for the future. You see, our source material looks ahead at emerging technologies, like real-time intraoperative navigation, that gives surgeons this unprecedented view during an operation. And it makes you wonder, are we on a path to a future where this kind of high-stakes surgery could one day become routine, and maybe, just maybe, truly risk-free? It's definitely something to think about.